Hi, everyone. It's great to see you here. Here as 2023 is coming to a close. And thank you for being with us these last 6 months. So as you're coming in, please do type into the chat your name, your organization, county where you see patients, and maybe one highlight from 2023 as you're looking back, and we're looking forward to the new year, hoping that it brings good things, maybe better things. So I think most of you know me. I'm Joanne Jung. I work at UCSF as a general pediatrician. Most of my patients that I see are here in San Francisco County, but I do some work in Oakland and Alameda County as well. And I would say highlight from 2023 was like being able to speak at the AAP National Conference. That was a real privilege to talk about healthy mental and emotional development. And I think the perspective that we pediatricians have, which is really preventative and building up strong kids from the ground. So would love to hear your thoughts. Please do type into the chat these things, your name, organization, county where you see patients, and a highlight from 2023. And so with that, let's go ahead and move on to the next slide. So again, we're coming from everywhere, all over the state. And it's good to have us here kind of as a community. So if you can keep your cameras on, that would be fantastic. This is a lunch hour. It's kind of like the virtual brown bag lunch type meeting. So please feel free to eat, take this time. But we'd love to see your faces if possible, especially during our case discussion time. We will be recording the didactic part of this presentation, so we can like post the recording up later for folks to see if they missed today's session. But only that portion will get recorded. And finally, there is this thing called the CAP Core Badge. I think we mentioned last time, but for those who showed up to all 6 of these echo sessions, we consider this our core curriculum covering ADHD, anxiety, depression, use of SSRIs, assessing for suicidal risk, and understanding the basics of autism spectrum disorder. These are what we consider the core topics. This is our core curriculum. We're going to be awarding you a virtual badge that should sync up with LinkedIn and may go on to CVs and things like that, just as a way of recognizing the hard work and the commitment that you've put in. So it might take a little while into 2024 for these to show up, but we do want to just share this recognition with you along with the CME that you're eligible for. And that's for those who showed up to all 6. We do have another Echo series coming up starting in January on the same cadence, the second Wednesday of every month. And this is this is what we call our advanced series, talking about eating disorders, disruptive behavior, trauma, early childhood mental health, sleep, substance use disorders. And so hope you can join us for that and spread the news to others. I think the announcement should have gone out on the listserv, but I wanted to call that out. And wanted to express a huge thanks to all of you who have been coming like month after month. It's been fun to get to know you a little bit. And thanks especially to all our case presenters so far. I know it takes a little time to prepare and get the information together and to share your learning with us. But this is how we all learn. We are all teaching, we are all learning, and we definitely learn from each other's experiences also. So I know I've personally enjoyed it, and very grateful for all those who have taken that additional step. And so finally, if you have not yet shared a case, or if you have not shared a case as part of this, if you want MOC Part 2 credit for the American Board of Pediatrics, there's a post test that should be coming, and that link should be coming by survey after the close of this echo session today. So be on the lookout for that, and hopefully get this complete in the next week or two so that we can get the names off to our CME office to get you that MOC Part 2 credit. And the MOC Part 4 activity, that's all already been wrapped up, done, and sent over. Hopefully people should be seeing that credit showing up on their ABP transcript soon. So let me know if questions come up. But with that, let's go ahead and move on to the next slide. I'd like to introduce our speakers for today. Our topic today is suicide prevention, a hugely important topic I think that many of us have struggled with in various ways through our practice. We have today Shelly Nakaishi, who is a certified pediatric nurse practitioner here at UCSF Benioff Children's Hospital, Oakland, in the psychiatry department here since 2006. She provides outpatient psychiatric medication evaluation and medication management to children from ages 3 to 21 in psychiatry, and also at the Castlemont school-based mental health clinic. She also participates in providing psychiatry consultation educational trainings through UCSF's CAP program here, including this one, including presentations on suicide assessments in primary care settings and trauma-informed care. In addition, Shelly has helped to co-create and teach a UCSF School of Nursing course on treating pediatric mental health conditions in primary care settings. We also have Hohui Eileen Wang, who is a clinical assistant professor in the Division of Child and Adolescent Psychiatry here at UCSF. She provides outpatient care at UCSF Benioff Children's Hospital, Oakland, and in the West Bay in the Brisker Building. She leads a teaching clinic and works with trainees at UCSF Benioff Children's Hospital, Oakland. She also staffs the UCSF Child and Adolescent Psychiatry Portal, CAP here, and is part of the CME team, helping to develop the educational content for pediatric providers, plays an important organizational role here in organizing all our activities. Her research interests include medical education, PTSD, sleep, and the gut-brain axis. So with that, I'll hand the virtual mic over to Eileen and Shelly.
Thank you, Joanne, for the nice introduction, and we'll delve into our topic today. Next slide, please. So our disclosures, there's not any relevant financial disclosure for myself and Shelly regarding today's talk. UCSF CAP program is sponsored by federal and state funding, and you can take a minute to look at the details of it on the slide. Next slide, please. So we want to thank you all for coming during the lunchtime today. I know your day is very busy. Before we get started, we do want to kick off with a Zoom poll just to gauge our understanding of your utilization of suicide screeners in clinical settings. Your input is very valuable for us and will help us to continue improving our presentation materials. So thank you. If you can use your camera to point at the QR code, it will lead you to a link. You also can use the tiny URL to go to the link, and then there's a question, and put in your vote. We will look at the percentage and how people answer that question. So the question is, how frequently do you utilize suicide screeners, such as ASQ, Act Suicide, SBQR, or CSSRS in your clinical practice?
Hi, this is Abby. Sorry, is it possible for you to put that URL in the chat? Because most of us are using our mobile devices and it's hard to, thanks.
Yeah, thank you. Thank you for that reminder. We do have our program manager that just put the URL, the website address to chat, and you can also copy and paste it. So we'll give it a few more seconds. The votes are coming in. So 33% of our participants today use the suicide screener about every 3 months or more. And weekly and monthly usage are in the tie. They're both around 20%. There are some people who do this almost on a daily basis. So 10% of our participants today do suicide screening almost on a daily basis. Wow, that's pretty frequent. So I hope that today our material will be informative and helpful to your practice. So we're still seeing that most people do it less frequently at every 3 months. And then now the daily, weekly, biweekly, and monthly are all in a tie. Pretty similar in terms of the frequency. Thank you for letting us know. And next slide, please. So here are our objectives for today. Our focus today will be on 3 vital aspects of suicide prevention and management. We are going to explore suicide screening tools, suicide safety assessment tools, and finally dive into intervention, including safety plan, lethal mean reduction counseling, and disposition. Our goal today is for you to feel comfortable with universal screening for suicidality and also feel confident in delivering the suicide safety assessment and treatment plan. Next slide, please. So I'll hand it over to Shelly.
All right. Thanks, Eileen. And thanks for the introduction, Joanne. So primary care providers, you are experts at identifying problems, assessing severity, and developing a treatment plan. You are experts at care coordination, prioritization, and continuous monitoring of chronic problems. And when someone comes in with a stomach ache, you figure out if they need to go to an emergency room. Next slide, please, Michael. So when I first started psychiatry, I was trained as a pediatric primary care nurse practitioner. And so when someone said suicide to me, my heart started racing. It still does. And my brain starts to get a little foggy. But after lots of practice and training and getting myself back and grounded in my problem-solving abilities, I find that I'm less stressed when I start to ask my direct questions of really trying to figure out how significant is this problem of suicide. And if you could hit forward, Michael, because I have a little fun arrow. So suicide is a target problem. And if we think in that way, then we will ask the questions of when is this happening? Where? How long? Have you made any attempts? What are you planning? What are your thoughts about this? What have you tried, not tried? Who have you talked to? So if I think it's a target problem, I'm going to go back and ask those same questions, those old cart questions. Next slide. And so suicide is preventable and treatable. One of the things about suicide is it is the severity level is dynamic. It's going up and down, up and down. It's not all at once. It can come in waves. It could be a short amount of time or it could be a long amount of time. And so really assessing how significant or intense those feelings are is part of your assessment. And this is, a slide to kind of show the waves and the kind of like you could be fine, but then you could actually go from having some thoughts, then you can add, there might be a plan. So it goes up intensity levels over at different times. And one of the things on the far right, what it's showing is, in 2019, there was a youth risk behavior survey. 19% seriously considered suicide, 16% had a plan, 9% had an attempt, and 3% actually had to see a doctor after an attempt. So this kind of helps to see suicide thinking and behaviors as a continuum, and that not everyone who is suicidal will make an attempt. And so not everyone who is suicidal needs to go to a hospital to be evaluated. The other part to consider is that teenagers are very impulsive and they have risky behaviors like substance use. And so understanding the risks and the impulsivity is part of our assessment as well. About 48% of suicide attempts actually occur within 10 minutes of thought. So if we use anticipatory guidance and we know there's risky behaviors, we can, provide families with safety information about restricting access to lethal means like firearms and medications, and we can save lives in that way. Next slide.
So thank you, Shelly. And then I just wanted to echo what Shelly just said. Doing suicidal assessment is similar to prescribing an SSRI. It gives you a stomach ache in the beginning, but the more that you do it, the more comfortable that you feel about it. So it really takes a lot of practice. Even for people like Shelly and I, we see psychiatric patients every day. Over a period of time, if we don't do this, we start feeling a little bit rusty about our skills. And then we can easily get back on track by reviewing some of the materials that we're going to talk about today. So here is the summary of the AAP blueprint for youth suicide prevention. This is a 3-tiered pathway that begins with a brief suicide screening. That should be done from the research. It shows that it generally is completed within a minute. And on average, it takes about 20 seconds. We'll show you the screening in the next slide. And just wanted to also let you know that after the first tier, the second tier is a brief suicide safety assessment for anyone who screens positive from the screener. And the assessment is different from a screener. The assessment is for us to be able to evaluate the frequency of suicidal thoughts, plans, setting, and also their suicide history and the current suicide patterns, and also their comorbid psychiatric symptoms, social histories, and all the risk and protective factors. By using the information that we gather from the brief suicide safety assessment, then we will be able to proceed to the final component of this pyramid, which is to identify the next steps for care, so that we'll be able to deliver interventions, including safety plan, including lethal means reduction, psychoeducation to parents, as well as deciding the patient coming back to the clinic or going to mental health clinic or going to the emergency room. Next slide, please. And this is the first step, the 20 seconds thing, which is here we present the ASQ suicide screening questionnaire, but you can also, if you feel more familiar with other templates like CSSRS or SBQR, you're also welcome to use them. The questionnaire can be self-report or completed with a nursing staff or technician. It has been validated, being delivered in those by those methods. We just have to make sure that the youth is alone when they're answering these questions, but not with their caregivers, because we want to make sure that those answers are valid and true to how they're feeling in the moment. Ask the questions directly and calmly, and just as is, with passion and with compassion towards the patient. There is a chronic myth about suicide screening would trigger suicidality. And a lot of studies really had been looking into this, and it's proven that it is not true. So we should not be worried about triggering the patients by screening them and asking them these questions. We'll turn it to Shelly for the next slide.
Next slide, Michael. Oh, yeah. All right. So if you could hit forward 2 times to Michael, perfect. So just going back, you're a compassionate detective in problem solving and really, trying to assess how severe is the suicidal thinking or planning, using the old carts. And the specific characteristics around suicide is more questions about the planning, access to the method, past attempts or interrupted attempts, what might be in the plan, if they've done any behaviors like collecting pills or posting notes, and then if there's also any self-injurious behaviors. And then the next level is using the same principles of the heads, is really to gather the risk and protective factors. So a lot of the assessment tools, the brief suicide assessment tools that the AAP recommends, actually pretty much covers, this type of an assessment that you're doing, that you're familiar with. And this is actually what should be charted as well when you're doing your documentation, along with your clinical risk assessment and your disposition treatment plan. Next slide. So how do we kind of balance out what is the risks and what should be the next plan? This is the risk assessment that is for right now, for today, for them in front of you and talking to you. So it's in this moment of time, and it's often categorized by low, moderate, and high. And it's really all based on how much of the suicidal thoughts and ideation and plans and how intense it is. What are some of the risk factors and protective factors, and balancing those out. Of course, this is all within your judgment as well, on your clinical judgment. The critical thing is not everyone is required to go to an emergency room to be evaluated for a 55-85. But the key messaging that the AAP is trying to really do is that we should universally screen people all 12 years and up, at least once a year, and even if they're not depressed, and determine the severity of the suicide. My other thing that I like to think about is a risk assessment is is not a prediction of if there's suicide. It is a way to identify what are the treatment needs, like treating underlying mental health conditions, or maybe it's a school bullying issue. And it's really an opportunity to do anticipatory guidance about safety, crisis planning, and reduction of mental health stigma. Next slide.
So this is to conclude what Shelly just shared with us about the risk and how to determine different levels of risk. And once we're able to identify whether the patient is at low, moderate, or high risk, then we'll be able to follow up with a different kind of type of plans for each different level. Note that sometimes the level may even change when you're going through the step of giving the intervention, because while we're giving the intervention, it includes building a safety plan. You may discover more information that actually moves the patient risk level from moderate to high or vice versa. And this is not uncommon. So the whole process of doing a suicidal screening and assessment is very fluidic and organic. And every moment that you're speaking to your patient and speaking to their caregiver, either together with the patient or in private to gather more information, all the information that you gather through at any moment will go into your consideration. So that goes back to what Shelly mentioned about kind of your gut feeling, along with all the information about the patient's history, their supportive system, and the risk and protective factors. So a few key points for the low-risk patients. AAP guideline recommends really just giving all of your patient, regardless their risk level, resources, as well as crisis number and text number. So the crisis number now has changed to 988 for it to be easier to remember. And the text line is texting home or whatever word to 741741. And CMSA actually just released their annual report showing that the text line has a really high utilization rate, sometimes even higher than the call line, because the teens are a lot more comfortable sharing their feelings and their crises over texting someone instead of like being on the phone and talking to someone. So that's a really huge message for all risk level of patients. They should be offered resources, local community resources, as well as crisis numbers and text number. For moderate and high risk patients, safety plan is a must. And we will talk a little bit more about the components of safety plan later. And for the high risk patient, one thing that's different and specific is that the patient needs to be started on one-on-one precaution. So the patient should not be left alone unless the next step of care is confirmed. Otherwise, they shouldn't leave your clinic. We'll move on to the next slide and talk a little bit more about safety planning, since this is really the gist of our intervention for moderate and high risk patient. So the main three components for safety planning is, first, we identify what are the warning signs and coping skills for the patient. Second, we identify what are their supports, including their family, loved ones, friends, as well as the professional supports, who can be their school staff, therapist, their pediatrician, their PCP providers, their psychiatry providers. And also, finally, it ends with lethal mean reduction and educating the teens and also their caregivers about how to keep their environment safe. Safety planning, you can consider doing it for some of your low-risk patients too. It's not that low-risk patient definitely would not need safety planning at all, especially when you have more concerns about some of your low-risk patients who don't have a good support system or don't have very good coping skills or do not really understand how to recognize their warning signs. It's always good to keep safety planning in your back pocket as well, and then build it with them so everyone can have a safety planning when their suicidal ideation or behavior comes up for the next time. Next slide, please. Building the safety plan is a collaborative effort. So I usually don't do it for my patient. I'll usually tell them, in my mind, it's kind of like I'm the coach teaching them to drive, and they're actually in the driver's seat. So I'm just being in the passenger seat, helping them to put this together. And then we'll make sure that everyone has a copy so they can all use it or have access to it when it's an emergency. A trauma-informed approach can be very helpful when we're building a safety plan with our patients and family. Not being non-judgmental, being curious, open-ended questions, empowering our patients and offering them their own voice and choice, listening to what they have to say. And we can see here on the left is a summary of the patient safety plan template on the right. This is just one of the templates. This is called Stanley Brown, but also you're welcome to build your own template if there's one that you like to use that incorporates more of your clinical styles and the way that you will gather certain information like heads and risk factors. You can use that too. And then you can see it starts with warning signs and coping strategies, followed by identify social people in social settings that provide support and distraction, and also family, friends, and professional support that they can contact when they're in crisis. And the final step 6, is lethal means removal, and then teach them how to make the environment safe. Next slide, please. We mentioned lethal means reduction multiple times already in today's talk, so you know how important it is. And one reason is because suicide attempts happen most often right after a suicidal thought. And then it's usually very quick. And teenagers can be impulsive. Their prefrontal cortex is just not fully developed yet. Especially they will often resort to guns, ropes, long cords, medications. So these things are usually on our top list when it comes to lethal means removal or reduction. And it's important for us to share this with caregivers as well, because most parents do not know about this. And some will even keep these things in like vicinity of where the teens can access them. Next slide, please. This slide is to conclude what we talked about earlier about the AAP blueprint. It was released in early 2022 after the mental health crisis that was announced in 2021. And it was developed by the AAP along with ACAP and also ASFP, the Foundation for Suicide Prevention. And the key messages from this guideline are, first, suicide is different from depression. From research, it shows that there are still about 4 to 10% more patients who have suicidality, even if they don't have any anxiety or depression symptoms or diagnoses. So if we only use PHQ-2 or PHQ-9 to do the screening, then we are missing a substantial amount of suicidal patients, and that's really scary to let them go. So that's why in 2022, the blueprint really encouraged us to kind of shift the way that we practice and consider using a new template. Either there's a template that incorporates both PHQ-9 and ASQ, so you just have one page instead of pulling multiple pages for the patient to fill out. There are already many, many forms. Or you can consider having your clinic staff routinely collect ASQ before you see the patient, because it can be either self-report or administered by technicians or MAs. The other message is suicide very commonly comorbid with different mental health problems, not just anxiety and depression, but also ADHD, impulsivity, transgender issues. So again, that speaks to why PHQ-2, PHQ-9 itself is not enough. And some new understanding about suicide, not all youth who have suicidal ideation are severe. Actually, most of the patients that you do screening with are gonna end up being okay and not suicidal. It's just a very small portion of these patients would eventually go to the other side of the continuum that they're seriously consider suicide. But we need to do the screening universally so that we're not biased, because there are certain type of patient that we will see them and feel like they're probably not at risk. But if they're not asked, they're never gonna tell. And universal screening is really helping us to avoid those biases and be able to kind of catch those patients who we might miss. Next slide, please. Okay, and we're gonna switch our gear a little bit. I know we're almost at time, and I just wanted to talk a little bit about kids, younger kids, because this becomes a rising problem for younger kids as well. Suicide is the second leading cause of death for 10 to 14 years old, but it's coming up to the fifth leading cause of death for 5 to 9 years old. And a lot of times these younger kids, the reasons why they self-harm or threaten to kill themselves could be different from older kids. And sometimes these threats have something to do with issues of being in control, and adults react emotionally to this word. Suicide can be reinforcing as well. Next slide, please. So interventions include lethal means restriction, because younger kids are even more impulsive and they don't think a lot. When they feel something, they just go ahead and do it. The treatment for comorbid condition is very important, and ADHD can be one of the reasons why these kids kind of jump from I feel sad to I'm gonna die. Behavioral analysis is really the key, and behavioral analysis will also help us elicit the coping skills and finding solutions for these suicidal behaviors. Michael, can you click again and see if the graph shows up? Okay, so behavioral analysis, in short, there's a mnemonic ABC. A is antecedent, B is behavior, and C is consequence. So basically follow this kind of flow. We identify the triggers and then figure out what kind of behavior gets triggered by certain antecedents. And finally, how the environment, including the teachers, the school staff, the caregivers, respond to it, and whether it's rewarding the behavior or it's decreasing the behavior. And that will give us some clues to how to design coping skills, or how to train the child to have better coping skills to reduce the suicidal behavior. Next slide, please. Okay.
This is just an overall picture of, before you start doing the screening, is to make sure you get leadership involved, use a cultural trauma-informed lens of how to roll this out, make sure everyone is trained, including from the front desk to, anyone involved in the clinic. And after we call it a code gray, whenever we had a crisis, psychiatric crisis in our outpatient clinic, we would continuously reevaluate it. What do we need to change in it? So in our code gray policy, we kind of identify what each person's role is, how this person would be transported to, or if needed to the emergency room, when do we involve security if needed, and so forth. So it just highlights all the things to consider before rolling this out. And to be really trauma informed about it is to make sure that you really think about all these things before rolling this out, because we're asking more and more, for primary care providers to do. Next slide. The take-home message here is really that use your relationship, therapeutic relationship building skills to listen and connect and assess. Not everyone will need to go to the emergency room, and to be very compassionate that this is intolerable pain, and their way out of thinking is suicidal thinking. So we're rebuilding their coping skills versus having this thought about wanting to die. Then there are lots of tools out there to do these screenings and the assessment. And also want you to, again, trust your skill sets in doing target problem solving. And the biggest thing to leave is restricting lethal means saves lives. So I know we want to do the echo part, and we also want to answer a few questions about something that came up around safety plans, which is we don't call it a contract because it's a collaborative plan. It's always being updated. Sometimes the word contract could have connotations to it, like what if I break it? Then it's not, I don't want to break it, or I don't want to tell you things because I don't want to break it. So we really want to use the language of this is our current safety plan. We'll revisit it. It's collaborative in that regards. Hope that answers that question.
Fantastic. Thank you so much, Shelly and Eileen, for this great talk. So for those of you who have a few extra minutes and want to continue the conversation, we'd love to hear what's on your mind now. Like, have have there been patients for you? Are there questions that came up in the course of this case that you want to keep talking about? So open to use this time as seems fit to this group.
I just want to make sure it's an okay approach to, because I'm always getting everyone to cry all the time, and every female adolescent, I have a one-shot thing. I'm meeting, I retired actually, and then I started to work, and now so I just get them dropping in, female adolescents, and they're all depressed and suicidal. So it's like I have a one shot to help them out. And if I refer them, you can't get in. So for weeks and weeks. So I'm trying to at least break down the barrier with that PHQA and get the parent to recognize what's happening with the kid, and then they both at least communicate and they're working on the same team. Now maybe it's too aggressive because they're always crying. Everyone's always crying all the time. I mean, I think it's working, but is there a better approach? I don't know. Because you guys would know better. Is that a, I think it's working, so or is there a better way to do it?
I think what you've been doing is great. I'm so glad that they cried. It's speaking to that they are communicating their problems, and a lot of times we really see the bigger problem is they don't talk about it and they don't
Right.
care to share. And so it's just amazing that they're able to open up to you like that.
Okay. So I
That's
just,
often the
yeah, I
first
don't
step.
think, okay, it's working. I just, it's an odd approach, and we're set up not to address mental health because we don't have enough time. So I'm always running behind also, but if I don't do it, no one's going to do it. So that they're just sloughing in, and then I'll refer them and I'll try to keep them going until they can slot in somewhere. But okay. I just wanted to make sure it was okay.
I mean, the crying
That's
shows
it.
that emotional connection, so I think it's good too. Yeah, like you broke down the barrier, like you're saying, and there's like a emotional resonance there with the communication. So I think it's great too.
Okay.
The
Because
first
I'm
step
not
into
bonding with
healing.
them. I'm just getting them to bond. I'm just there one-stop shop, get them to bond, go out, and maybe I'll follow them a couple of times and then out. Okay.
Yeah, I think this is like so
That's all
tough.
from the PHQA that made it easier. Yeah.
Mhm.
Thank you. Sorry.
I think it's hard because I feel like it would be so great. I mean, they talk about it, right? Like at the Stanford like mental health thingy, like there's only ever so many psychiatrists. And really, if we can get like these big, like just parents, like just the parents and parent coaching slash parent, into this, even in a community type setting, where the different parents come together. But I guess in this case it's a little harder because, like she was saying, the dad, is not as willing or whatever. But even if the mom could, like, I just feel like because there are not enough psychiatrists, that's like Stanford's like, approach there is just like target the parents, right? So I don't know, it's like a lot of parent education and training, like when you have a child who's got anxiety or this or that, like coach me, like what are the words that I'm supposed to say, how am I supposed to say it, and if she acts like this, what do I do? And then there's a sense of community too, because there's other parents also involved in that. I kind of like did something like that with my child, like regarding like social pragmatic style training, and it was really really helpful, like, and it was all like parent based. It was like, my son wasn't even there. So anyways, I wish something like that, but just a thought.
I mean, there is
we
parent
bet-
education out there for sure, to help with like anxiety, help kids with anxiety, but I don't know, I just interrupted somebody.
Oh, I was gonna just agree that I think, yeah, definitely parent targeted interventions can be really powerful. And I think one thing that can be helpful too is like, even like we think about this with kind of like ADHD and stuff too, that's often our main the behavioral modality is more the parent target rather than the kid, is that if we're able to support parents in implementing kind of the strategies, that it's actually a much higher dose than what they could get from meeting with a therapist once a week. And that also they're kind of more likely to be there in the moment, that when when the crisis does happen, it may not be when they're seeing their therapist, but often the parent would be there.
And I find a perspective helps me that anxiety, depression, ADHD, these things often run in a family. So sometimes it really makes sense why it's so hard for the parents to open up or to recognize that, because they themselves exactly struggle with this too. I appreciate that AAP and the MINH, the ASQ flyers do have a parent flyer, and that sort of breaks down the barriers for them to be able to talk and think about suicidality. So if you have any patients that is real low risk, I think it's worthy to distribute that to just help them to understand a little bit more about what their kids are thinking.
Yeah. There's something in Stephanie's approach too about getting parent and child to understand each other a little bit better, that it can be really like transformative also. Like those times when parents can understand and empathize a little bit more, I think can really change the dynamic in powerful ways. And so there is something in that I appreciate it.
And I think it can be too, so like sometimes with like the kind of self-harm or SI, sometimes there's teens will describe kind of feeling like that's what they're like in their brain, they're feeling like that's what they need to do to express how distressed they are. And I think for all of us, if there is that sense of like, maybe I'm distressed, but I don't know how to express it, or I feel like my parents aren't taking that seriously, that if we can be a person to help them, you know, when they're filling out the PHQ-9, help the parents understand that the kid is or teen is distressed, and this is something we're taking seriously, they need to take seriously before it gets to that point.
Yeah. Absolutely.
Good too.
Other thoughts or questions that are coming up for people around this issue, because this is one of the truly scary things, you know, that will confront us. And I just had a 12-year-old who just got released from psychiatric hospital after a suicide attempt, downing a bunch of his meds. Well, actually happened to be melatonin because that's what he could get his hands on, after trying to down Windex, after trying to down other like cleaning supplies that his parents probably took away from it. And they discovered him in the bathroom, like just carving up his neck with the biggest kitchen knife. I mean, all the cuts were superficial, but into the hospital he went, and he was 12. Right. ADHD and depression. Like we knew all the, you know, and it anyway, he never had a plan, and he never acted on one until he did.
It is kind of scary. It's like knowing like kind of the and I appreciate what you're presenting, because the kind of like the low risk versus, I remember, again, not to get back to this whole social pragmatic thing, but I remember when I was actually part of like a training when I was talking with a speech therapist, but like, you know, like if, you know, like my son would like, if he becomes overwhelmed, then he would say like, you know, oh, I'm going to go kill myself. And then, you know, that triggers emotions in me, because I'm like, oh my gosh, like, do I need to take this seriously? Like, what's the risk level? Kind of like what you were describing, right? So, you know, and I didn't know like how to like whatever. So then, you know, of course, you had to like calm me down. Then I would get, you know, do I need to take him to the doctor? Like, what do I do? Of course, I can't be objective with my own kid. But then, you know, it really worked out in which she was, you know, the speech therapist who works on social pragmatism was basically like, he just doesn't have that verbiage to be able to say, like he's frustrated because he's like, she's like, think of the context that he's saying it in. Is he having it when he's like totally calm? And I'm like, no, it's always when he's overwhelmed. And she's like, okay, then that explains why he's saying it. And so she's like, why don't you repeat back to him, like what, give him the language, like what is he feeling, right? And we talk about that, I guess, in psych a lot too, right? Just give the language to the feelings, and that already tends to calm you down. Oh, I hear you saying you're feeling angry. I hear you saying you're overwhelmed. I hear you saying you're frustrated at the teacher for all this homework or whatever it is. I hear you saying that you can't, you know, and I did that, and literally, and like, just it did escalate, by the way. It's like that whole like extinction burst. It escalated, and then I was just very calm and consistent, and it went away, hasn't said it since. So I thought that was also helpful to like put your own check on your own emotions.
Yeah, thank you for sharing that. And that was part of what we want to share about the ABC behavioral analysis, because thinking about like when we are calm in our wise brain, we start thinking about what triggered it and what was their behavior and what was actually inadvertently rewarding certain things that they were doing, and then try to cut down on the rewarding consequences and also reducing the triggers will be helpful, just like what you just mentioned beautifully.
That is beautiful. Well, thank you everybody for staying over for a couple of minutes. And thank you for, as I said, for joining us these last 6 months. It's been a pleasure, and hope to see you around at some of our other events as well.